is Jordana Clark, and I am the Education Coordinator here at the Australasian Society of Lifestyle Medicine, or ASLM. Thanks so much for joining us for today's webinar, The First 100 Days. So we're looking at what needs to change in the way we care for parents with babies. For those who are new to our society or to lifestyle medicine, I just wanted to take a few moments to introduce us. ASLM is a multidisciplinary society made up of GPs, allied health professionals, public health professionals, educators and researchers, amongst others, who are all working towards improved prevention, treatment and reversal of chronic and lifestyle-related diseases with the use of lifestyle medicine. So this involves dietary modification, regular physical activity, adequate sleep, stress management, smoking cessation. And we also look at things such as the social and environmental determinants of health and advocating for policy change to address the upstream causes of chronic disease. So if any of this interests you, please feel free to check us out. We have a board certification program, fellowship program. We have a conference coming up in Melbourne in May next year. And to find out more about that, you can take a look at our website. So just before I introduce our presenter for today, I'd just like to go over some technical aspects of today's webinar. We have an allocated time at the end of the webinar to answer any questions you may have. So if you have a question that comes up during the webinar, I encourage you to type that into the Q&A box. You should be able to see the Q&A box down the bottom of your screen. Sometimes it doesn't display and you just have to hover your mouse over the bottom edge of your webinar window and it should pop up. And this displays as a black bar with the Q&A button. We will not be using the chat or the raise hand feature for this webinar, so just to be aware of that. Okay, so without further ado, I would like to introduce Dr. Pamela Douglas. Pamela is a general practitioner and researcher with a special interest in early life care. She is an associate adjunct professor with the Maternity, Newborn and Families Research Centre at Griffith University and senior lecturer in the discipline of general practice at the University of Queensland. Pam is the medical director of Possums Education and Research Centre in Greenfields, Brisbane, and founder of Possums for Mothers and Babies, a charitable organisation which educates parents and health professionals in community-based neuroprotective developmental care, or NDC. NDC is an innovative, integrated approach to problems relating to breastfeeding, crying, sleep and mood in the first year of life with an accreditation pathway newly available for health professionals. She and her colleagues have been developing and publishing the NDC evidence base in the medical literature for over the last 12 years. A big warm welcome to Pamela.
Thank you very much, Jordana. So it is a great privilege to be here today with ASLM to talk on a topic that's very close to my heart. The first 100 days post-birth, what needs to change in the way we care for parents with babies? Here we are in Australia, really with one of the best health systems in the world. And I like to say that we're really at the tail end, both here in Australia and internationally, of a century-long revolution, really, in the healthcare of women and their babies. So between when my grandmothers were born and today, we've seen a dramatic decrease in maternal mortality ratios and infant mortality rates, and a dramatic decrease in maternal and infant morbidities. However, I argue that this century-long revolution will not be finished until we've completed the next phase of our improvement in the healthcare of women and their babies, which is all about supporting parent-infant biobehavioural synchrony or neurohormonal synchrony, or supporting parents to get in sync, to support that secure psychological attachment of their baby and to enjoy those lovely lengthening reciprocity chains. You here don't need me to be impressing upon you the significance of the developmental origins of disease. There's been, in recent years, a growing focus on the first 1,000 days of life, from conception through to the end of the first 2 years. And it's been wonderful watching this awareness grow throughout my lifetime. But I would argue that we still do the first 100 days post-birth relatively poorly as a health system with respect to the common problems of infant behaviour and the ramifications of infant dysregulation for maternal and parental mood. The first 100 days is characterised by 3 biomarkers of injury-sensitive neuroplasticity. And I've just last week had a new paper come out that looks at this through the lens of autism spectrum disorder, but this holds true broadly for infant development. In the first 100 days, we see persistence of the cortical subplate, which is laying down those neural templates, then taken over by the cortex after about 3 to 4 months. We see, of course, this crying diathesis, the tendency of babies to cry in the first 16 weeks of life, and peak monoaminergic excitability actually from birth through these first few months of life. So I would argue that right from this critically sensitive first 100 days, disrupted trajectories of development is mediated by chronic sympathetic nervous system, hypothalamic pituitary adrenal axis hyperarousal. So this alters the regulation of the epigenome, which turns on and off that underlying genetic susceptibility or modulates genetic susceptibility, and also is so critically important if we have an infant or family who are psychosocially vulnerable. So these are the most common problems then that parents face in the first 100 days after the birth of their baby. The dysregulation of adult mood, breastfeeding and infant feed challenges, challenges concerning parent-infant sleep, and dysregulated infant behaviour, crying and fussing. And parents tell us that they receive huge amounts of conflicting and confusing advice when they seek support from health professionals for these common but distressing problems. So as a consequence, parents will go from provider to provider, including to emergency departments, seeking the help that they need. And I would argue that this problem of conflicting advice and opinion-based advice, which wouldn't be tolerated at any other point in the lifespan, actually drives up parental anxiety, which of course predisposes to postnatal depression. It also, of course, results in wastage of the precious health dollar. This is also a time of life that's characterised by widespread inappropriate medicalisation of infant behaviour problems, with all the unintended outcomes consequent upon that. The widespread inappropriate medicalisation of infant behaviour problems also disrupts capacity of the parents to read their baby's cues, because they're being asked to read those cues through the lens of a medical condition. As health professionals, we report that we have significant gaps in our training concerning breastfeeding support or the management of cry fuss and sleep problems. And indeed, the first 100 days post-birth is characterised by that real gap between evidence and practice that has been estimated to rest at about 17 years. So why is this the case? I propose it's due to a lens problem, where research is interpreted through the theoretical lens of various disciplines, but these theoretical frames are assumed, they're not explicit and debated. So of course, any data that we collect is certainly as good as the research question that we pose, and that the questions can be posed through particular lenses. But then the data itself is interpreted through lenses that are so often not clarified, that are assumed. And there's been work to show that because of poor theoretical frames, there's something like an 85% wastage in research, that so many of the studies that our health system research centres are investing in are methodologically poor and not helpful to the growing of knowledge. And similarly, it's been estimated that something like 50% of guidelines are reversed because of the lenses that are being used but not clearly articulated. So what needs to change in the first 100 days? I propose that before all else, we're needing content-aligned, evidence-based management of the common infant behaviour problems that present in this time of life. So we need investment in primary care research into clinical innovations in early life care, in an environment where there's been significant defunding of clinical primary care research. We're more likely to be able to obtain funding in primary care for health systems, health services, delivery research, but clinical primary care research is very difficult these days to fund. And yet there's been research to show that the guidelines developed in universities or in tertiary settings are very often not relevant to primary care clinical practice. This research was done in the UK concerning the NICE guidelines. So here we are, really needing a paradigm shift in the way that we care for parents with babies. And I would suggest that we're currently on the cusp of paradigm shift, here in the middle, moving between the old and the new evidence-based approach. And certainly on the cusp of paradigm shift, it's normal to find a great deal of turbulence. So interdisciplinary conflict, frustration from both health professionals and parents. So it's into this space that I, with various teams over the last 20 years, have worked to develop up neuroprotective developmental care, which are popularly known as the POSSUMS programs. So this is an integrated and interdisciplinary approach to the care of parents with babies, and has explicit, peer-reviewed and published theoretical frames. This is a great methodological strength of our NDC programs. And I invite those of you who are interested to have a look at those publications. If you go to possumsonline.com, under the research tab, you'll find a link through, or you can in fact go directly to my personal website and find PDFs there, either of the publications or, when necessary, due to copyright, of the final versions prior to publication. Our preliminary evaluations have been very positive, and certainly in the clinic we see the efficacy of what we're doing, and this is borne out through the work of our NDC accredited practitioners around Australia, and some now overseas, who are delivering the NDC programs. So at this point, by way really of declaration of conflict of interest, and also just to let you know, as Jordana was saying, Possum's Education is a small charitable organisation that has no external funding. And for this reason, although we now have a great deal of free resource available on our website, we nevertheless need to sell some of our products, and we do this as at as low a price as we possibly can. So now on possumsonline.com, parents can purchase the Gestalt online self-help program for breastfeeding, the sleep film. Both of these are also available with health professional licenses if you wish to use them repeatedly in your clinical or educational setting. We have the whole library of videos called the PIPS resources for parents associated with closed Facebook page support. You'll see that our introductory certification workshops are available online. The masterclasses are run face-to-face, anticipating 2 sets in 2020. And importantly to tell you about, there's accreditation available in NDC, and you can join up for that right now. It gives you access to a wealth of clinical tools, parent handouts, live network hours for case discussion support, content sharing, and so on, closed Facebook group. And just to mention that I aimed to take the evidence base of NDC and put it into stories that would speak to families in my book, The Discontented Little Baby Book. So from here, in our time together, I want to give you an overview of what I think needs to change, what using the NDC lens needs to change across these 4 domains of how we manage parent mood, breastfeeding, infant feed, sleep, crying and fussing. And just to mention that whilst I'm going to do my best, this is just a short time frame to give you a taste, really. And we spend days working through these clinical tools in depth in our education offerings. So let's start with consideration of parent mood in the first 100 days. And I want to say to you that there are 4 key modifiable risk factors for postnatal anxiety and depression. There's maternal anxiety clearly will predispose to depression. So upregulation of a mother or parent's sympathetic nervous system HPA axis. Antenatal depression, which of course itself has a strong component typically of upregulation of the SNS HPA axis. I'll just refer to this from now on as a dialed up sympathetic nervous system, or dialing up for short. Then upregulation of the infant's SNS. So cry, fuss problems predispose to parental mood disorders, in particular postnatal depression, and breastfeeding problems do the same. So importantly, actually, co-regulation of the infant behavioural state should actually be integral to any support that we're offering parents from the point of view of psychological well-being post-birth. So at the moment, the care of mental health is typically fairly siloed, separate to the care of problems of infant dysregulation and breastfeeding that arise. NDC uniquely integrates, argues that all of these domains need to be worked on together if we're to optimise parent mental health. And in our programs, we lean heavily on acceptance and commitment therapy. So contextual behavioural science or applied functional contextualism, a third wave behaviourism, is integrated into each of the domains of NDC. Why ACT? It's transdiagnostic, doesn't need to pathologise. It's empowering. It clarifies the parent's own values. It supports contact with the present moment, recognises the power of small changes, supports the growth of those reciprocity chains, cued care, supports experimentation, self-compassion. So we won't pause today to look at what are the strategies of ACT that we've adapted for the perinatal space are. But I did want to observe that teaching ACT, integrating it into our clinical practice is most effective when we're practicing it ourselves. And indeed, I personally have found ACT a very empowering set of strategies over the years. I also want to draw your attention to a freely available page on the possumsonline.com website, where with the help of the local Brisbane South Primary Health Network, we've put together a set of videos that share these key strategies out of ACT for parents with babies. So I'm hopeful that you may all find that a useful free resource for parents. So just to summarise, in this domain of parent mood problems, what I would like to see change, I think the integration of ACT into community-based post-birth consultations, and of course evidence-based and effective clinical management of infant feed, sleep, crying problems as a way of protecting and intervening for parent well-being, emotional well-being. So next, looking at the domain of breastfeeding problems, you'll see that I use the term fit and hold. We've been using that for many years now, instead of the more well-known term of latch and positioning, just because I think fit and hold is more parent-friendly. And you'll see we'll use this word Gestalt. It's a German word that's come to mean the whole that is more than the sum of its parts. There's no doubt that Australian women want to breastfeed, but by 16 weeks post-birth, only 39% are able to breastfeed exclusively. So by far the majority of our parents are feeling that they need to introduce formula. So of course, one of the things that characterises our NDC work in the breastfeeding space is that we're not attached to any particular ideological stand around breastfeeding, and acknowledge the benefits of formula in a world where actually clinical breastfeeding support is unfortunately not done very well. But formula use does come at a cost, both to health systems and to long-term, short-term health of the infant, and indeed there is a cost to the mother of formula use. The reason that parents give for starting formula come back to unsettled infant behaviour, often attributed by the parents to perhaps low supply, to hunger. Often also from a clinical point of view, the unsettled infant behaviour may result from a conditioned dialing up in that baby due to the unidentified and unmanaged breastfeeding problems. So parents will tell us that they need to use formula for unsettled infant behaviour, for problems getting the baby onto the breast, and for pain, for nipple damage. Now, for the whole of my professional life, there's been widespread inappropriate medicalisation of infant feeding distress cues, with the use of unnecessary pharmaceutical or surgical intervention. So the first wave of this that I saw from the late 80s was the diagnosis of gastroesophageal reflux disease, with in more recent years the use of PPIs, the inappropriate use of diagnoses of allergy to explain the infant's behaviour, inappropriate attributions to lactose intolerance, and more latterly diagnoses of posterior tongue tie and upper lip tie. The most commonly missed breastfeeding problems that are not being picked up as we resort to these diagnoses are suboptimal fit and hold, conditioned hyperarousal of the sympathetic nervous system, very often due to suboptimal fit and hold, or to accidental coercion, really, as a breastfeeding woman tries to make the breastfeeding happen, so worried about the weight gain, so worried that the baby needs to be at the breast that some coercion is used. Feed spacing actually in itself causes significant problems very often, and a true functional lactose overload is also often overlooked and misdiagnosed as, say, an allergy or a case of reflux, or these days a case of restricted oral connective tissues. So the behavioural signs of suboptimal fit and hold are suboptimal fit and hold, which causes the positional instability, are the difficulty coming onto the breast refusal, pulling off the breast, back arching, and fussiness just generally throughout the feeds. And as I was saying, this can lead to sensitive behaviour at the breast, or the condition dialing up, more commonly known as breast refusal or oral aversion. So, importantly, the most widely used breastfeeding support strategies have been shown in various studies to actually not improve breastfeeding outcomes. And it's not a very doesn't make me popular saying this, but unfortunately it's the case. So for instance, the widely used set of strategies that you can see in these slides have been clearly demonstrated in a very well conducted study to increase the risk of nipple pain fourfold. And unfortunately here I can't go into depth around any of this, but hopefully just giving you a sense of what's going on. The physiological breastfeeding initiation has been a major advance in clinical breastfeeding support over the last 15 or so years. This is skin-to-skin contact, what's known as baby-led attachment, a recognition of the importance of those mammalian feeding reflexes. However, unfortunately, the physiological breastfeeding initiation in itself is not sufficient to secure successful breastfeeding for many women. So I want to put to you a radical proposition that fit and hold problems are actually the most important obstacle to improved breastfeeding outcomes in high-income countries. And crying baby research, and indeed most clinical breastfeeding research, has this great blind spot, this omitted variable bias of fit and hold and positional stability problems. Into this space, in the last 10 years, has come this diagnosis of oral connective tissue restriction. And the rate of frenotomies in Australia in 0 to 4-year-olds, tracking Medicare data, decade 2006 to 2016, and this was work by a PhD student of mine, has increased 420% overall. And this mirrors what we've seen in studies in the US and Canada. But we think dentists are doing most of the frenotomies. And in the ACT, where there was no dentist doing frenotomies in this time frame, the rate increased, you'll see that top red line, increased 3,710%, which we fear is more reflective of the overall increase in the rate of frenotomies in our babies and small children in Australia. It's predominantly infants. So certainly a classic tongue tie requires a simple scissors frenotomy in the context of breastfeeding problems. And unfortunately, I can't spend time here going into great detail around what might constitute a classic tongue tie. But certainly the diagnosis of posterior tongue tie really has no place at all. It's a misconception, and in fact this has been borne out just in the last year by some superb anatomical dissection work done by my colleague Nikki Mills, an ENT specialist in Auckland, New Zealand. Similarly, our position statement, our team has put out a position statement on the concept of upper lip ties, arguing that there's no place for that as a diagnosis. The lovely anatomically diverse range of labial frenula need to be normalised, and cutting the labial frenula actually places infants at risk of later diastema, gaps between the teeth, despite what parents are being told, that if it's not cut, they'll get the gaps. It's the other way around. And we do need to be mindful that there are unintended outcomes to the inappropriate use of laser for our baby's oral connective tissues. I'll just do a little timing check. Just to let you know too that the concept of air swallowing is a misconception, and the subsequent burping and holding upright after feeds can be really very disruptive, and NDC would recommend that parents experiment with not engaging in burping and holding upright, because the baby won't be swallowing large amounts of air. This photo actually, which was part of the initial publication that made a claim around air swallowing and oral connective tissues, is, if anything, presuming it's an otherwise healthy baby, it will be a photo of a true functional lactose overload, nothing to do with air swallowing. So we have worked with the University of Western Australia Human Lactation Research Group, who are world leaders in the use of ultrasound investigating the biomechanics of infant suck. These are the publications if you're interested to go and have a look at them. to put together a novel approach to fit and hold problems that we call Gestalt breastfeeding. And it really is quite different to the other approaches that are being used at this time in clinical breastfeeding support. When we have use of the bottle, just to let you know, there's a free video on our website that demonstrates, my colleague Renee Keogh, does a lovely demonstration of paced bottle feeding, which uses the bottle in a way as close to the biological norm as we can. So there we are, summarising what needs to change in terms of clinical breastfeeding support in the first 100 days. So sleep, very big topic, source of great distress very often to parents managing sleep deprivation, and an extraordinary amount of conflicting and unhelpful advice. The dominant approach is the first wave behavioural or sleep training approach. You can see there the various elements of this package of advice that really came to the fore from the 1950s and 1960s. It was what I was taught in the 1970s when I had to attend compulsory mother classes in year 9. Actually, there are now 4 systematic reviews that show that the sleep training approaches do not decrease frequency of night waking in the first 12 months. They don't reliably protect against postnatal depression, and they do interrupt parent-infant cued care for many families. The first wave behavioural strategies, despite what parents are being told, don't improve sleep or developmental outcomes for their baby. And in fact, we're proposing in our publications now that it's the first wave behavioural approaches that may mediate this link that is observed between a small cohort of unsettled infants in early life and behavioural and developmental disruptions down the track, because the first wave behavioural approaches tend to drive up arousal of the SNS-HPA axis. So sleep training disrupts cued care, promotes anxiety and distress, and very significantly actually disrupts the infant's circadian clock and can make night waking a lot more frequent. So we've developed a new sleep intervention that integrates sleep science, lactation science, neuroscience, evolutionary biology, and acceptance and commitment therapy. It's important to distinguish between normal night waking, which will be every couple of hours throughout the first year of life, just wanting everyone to get back to sleep really quickly, and excessive night waking, which may be due, of course, to a passing viral infection or, in the little ones, unidentified breastfeeding problems, but is most commonly actually due to disruption of the circadian clock and the sleep-wake homeostat. And so in the possum sleep intervention, we repair disruption to the biological sleep regulators and support their healthy function into the future. So again, I've just put in these summary slides at the end of each domain to remind you of what needs to change. Now you'll notice there, in terms of dealing with sleep, I've also included this vital domain of environmental enrichment. And that's what I'm going to touch on now. Environmental enrichment, social, non-social. We talk about it in NDC as sensory nourishment, that babies have a very powerful biological need for rich and changing sensory input, and that they're laying down their neural templates in these first 100 days in direct response to rich and changing sensory input. And they'll cry inside our homes because our homes are so low sensory. So this means we're inviting parents, the primary carer, to be developing days rich in activities outside the home. So you'll see, again, a summary of what the domain of environmental enrichment entails. But critically, we stop problematizing stimulation, which belongs to the outdated first wave behavioural approach, actually, to sleep training. So cry fuss problems. I see I've got a few minutes before I need to wrap up, and that should give me time to run through this final domain. Again, huge amounts of conflicting advice that parents receive. We can no longer consider cry fuss problems benign, even though we can still look parents in the eye and say, the first 16 weeks is a time of neurological sensitivity and our babies are much more likely to cry. It will pass. As health professionals, we need to be aware that cry fuss problems are linked with an increased risk of postnatal depression, certainly child abuse, premature weaning, developmental problems in later childhood. Cry fuss problems are modifiable according to infant care practices. And in our NDC work, I've put together a 5-domain approach to cry fuss problems, which halves crying and fussing in our preliminary evaluations. I'd like to direct you to this little trilogy that came out earlier this year in the Medical Republic. That's an update around the NDC approach, the possum's approach to the baby who cries and fusses. That's freely available online, and you'll find those links again on my personal site, or click research on the possum's website. So we've already talked about the inappropriate use of proton pump inhibitors, which come with the risk of side effects for our babies. Maternal elimination diets are very commonly inappropriately applied to babies who cry and fuss. And unfortunately, eliminating foodstuff from the breastfeeding woman's diet actually increases the risk of allergy for that baby. It is worth noting that the diagnosis of gastroesophageal reflux disease in infants, and indeed the focus on maternal elimination diets for breastfeeding women, actually started in Australia. I've tracked this throughout my career, and I don't think it's a coincidence that Australia has the highest rate of paediatric food allergy in the world. It's true that crying and fussing is associated with intestinal dysbiosis. However, very often a simplistic cause and effect lens is being applied to this important research finding, and it's being said that babies are crying because of gut dysbiosis. That's much too simplistic. Gut microbiota composition is changed by crying, by that chronic sympathetic nervous system hyperarousal. Feeding problems will affect, of course, the gut microbiota, and of course the widespread use of those proton pump inhibitors and antacids affects gut microbiota. So again, I can only direct you to where the resources are around our comprehensive approach to cry fuss problems, but just a couple of little important things to flag. We don't need to worry about green or mucousy stool unless that baby has a true gastroenteritis. We can reassure parents. We've already talked about how it's really very helpful to invite parents to experiment with not burping and not holding up right after feeds, although we typically have to do quite a bit of work explaining why this is the case and bring them along with us because it is such a socially entrenched set of behaviours. To let you know, my dear colleague Renee Keogh has a 2-hour when baby comes home workshop that she runs here in Brisbane for expecting parents, but it's actually available for your patients as part of the PIPS program if you're interested. It's videoed. So there we have it. You'll see that we integrate ACT again into our management of cry-fuss problems. We cease the inappropriate medicalisation of infant behaviours and then offer our multi-domain intervention. So I'll draw to a close now. I want to remind you about the Accreditation Pathway. It'd be wonderful to have you join us if you're interested. And I trust there's time now to take some questions. Thank you, everybody.
Beautiful. Thanks so much, Pamela. That was incredibly interesting and such an important body of work.
Thank you.
Yeah, amazing.
I think it's important, so I'm glad you found it interesting.
So we have some space now for some questions, for some Q&A.
Yep.
So I'll just remind you that down the bottom of your screen, there is the Q&A box. So if you've got any questions for Pamela, now is the time to type into the Q&A box. So please take a moment to do that. And just while I'm waiting for that to come up, Pamela, I just wanted to ask you to speak a little bit more about the not burping and the not holding upright after feeding, because that is an extremely culturally entrenched teaching. And just to speak a little bit more around the reasoning behind that, I find that fascinating.
Yeah, yeah. Well, of course, burping, most human cultures don't burp their babies. In fact, you could argue that burping is a practice that spread with the British Empire, actually. And although babies will swallow a little bit of air, and they're capable of gigantically loud burps, actually, they'll do that burping whatever position they're in. They can relieve themselves of that burp, whether they're lying down on their back, whether they're in your arms. They don't need to be held upright to burp. Now, there's been a big focus. I watched it fade away, and then in recent years it's become, again, really dominant, this advice that babies, particularly if there's any breastfeeding or bottle feeding problems, are swallowing air. And that's why they're unsettled with the breast or the bottle feed, or that's why they're not going to give you a big block of sleep. It's a serious misconception. We know from the research, from ultrasound studies, watching the swallow, watching babies' tummies and other modalities, that babies aren't swallowing large amounts of air. And you see, it matters because when we hold a baby upright after a feed, the baby is typically really dialed down. If all's going well, is the way we want it to, with the breastfeed or indeed the bottle feed, it has an effect of dialing the baby down due to the cholecystokine and the activation of the parasympathetic nervous system, oxytocin, the cuddle and breastfeeding. So we've dialed the baby down, but as soon as we feel we have to sit them upright or indeed hold them upright, we're rousing them. So, we're rousing the reticular formation brainstem, and this means then that the little ones can often start to dial up, which may be interpreted as, oh, more air, that baby really needs to get the air out, so more sort of burping, holding the baby upright. The typical approach of holding the baby upright, I'm sort of doing something with my hands here, under the chin and literally sitting up. The physios will tell you it's really not good for our baby's musculoskeletal development. They need to be against our bodies with spinal support. So the classic burping position in itself is not recommended from the point of view of musculoskeletal development. But even holding upright on the shoulders, you've roused them. They can't see out very well anyway. They often don't like being up on the shoulder necessarily. Some will like it, but it's certainly not something that has to be done. You don't need to be putting them across the lap during breastfeeds to give them give them the opportunity to digest. There's a great deal of misconception about this, and it adds in layers of difficulty that's unnecessary. We want to make feeding our babies, and indeed sleep, just as easy as possible. And whilst often babies don't go to sleep at the end of a feed, sometimes they do, and we just want to allow that to happen. And then, you know, you might put the baby down and the baby wakes, which is often the way, that's normal, and then on with the day thinking sensory nourishment for that little person. So have I answered that question, Jordana?
Yeah, you have. And what I'm hearing there is really that the importance of that autonomic regulation, like the parasympathetic rest and digest response, that's an activity of the parasympathetic nervous system, and the need to be in that calm, like dialing down state, as you say, rather than that sympathetic activation, which seems to be a reoccurring theme for issues and problems that we're looking at here.
Yeah, that's right. That's right. I frame it with parents as we just want to make this as easy as possible, as uncomplicated as possible.
Yeah, and it's an interesting tendency that we have as human beings to seem to want to overcomplicate things that can actually be quite simple.
Yes, and look, the truth is there are often very complex and distressing problems in early life, but you know, that need really good clinical support. But there's also quite a lot that actually is iatrogenic, unfortunately, that arises out of the advice that parents are being given. Possum's education has the motto "growing joy in early life." We just want to grow enjoyment, make life as easy and as enjoyable as possible when we have that little one in our care. Because goodness knows, you know, primary carers are often having to return to work quite soon, and we just want those days when we are with the baby to be as easy and as enjoyable as possible.
Yes, absolutely, and to rest and digest the whole experience of entering into parenthood.
Yes, although it's important to note that rich and changing sensory input is vital. So lots of engaged play, for instance, in the evenings. We just don't use the concept of overstimulation. There's such a powerful biological hunger for rich, changing sensory input. So, yeah, I worry a little bit about the dominance of ideas of we've got to, it problematizes stimulation, so we've got to keep stimulation low in order to keep babies calm. It's the other way around, actually. Often it really dials babies up to be in low sensory environments. They're just hungry for the world.
Yeah.
Across all their senses, including vestibular stimulation, proprioceptive stimulation. And inside our homes is typically low sensory, and babies will dial up just because there's not enough going on.
Beautiful. Thank you, Pamela. I've got a question here in regards to hiccups. So Land is writing in saying, my baby gets frequent hiccups, and although he doesn't seem distressed, a lot of family members have commented that he should be given water. He's only just 16 weeks old this week. Is there any particular way this should be managed, or just wait until they pass? Yes,
just wait until they pass. Hiccups are biologically normal in babies. We just don't need to pay attention. It's not a reason to use water, actually.
Yeah, absolutely. The other thing that really interested me, is that the right word? Horrified might be a little bit. The 420% increase in frenotomies. That's astounding.
It is. It is. It's and it's reflected in research that's come out in recent years from North America.
And so in terms of like reasons why we're seeing this over-medicalisation of issues in early infant life, do you have any particular insights into why?
Well, we certainly live in complex socio-cultural environments that can disrupt, if you like, that bio-behavioural synchrony across feeds, across parent-infant communication, if you like. So parents come for help with that. And the bottom line, I would argue, is that the clinical tools that we've been using just aren't effective, actually. That there's this great historically constructed lack of research around clinical support for these problems in early life. And so health professionals have been quick to look for, if you like, the quick fix, the silver bullet, applied the medicalised lens, which, you know, does come easily for us in the medical profession, in ways that have actually been very unhelpful, because it's meant that the actual causes of that disrupted infant behaviour are not being identified, not being managed. So I see it as a kind of response to historical lack of focus on the care of mothers and babies. And in we come then, desperate to be useful as health professionals, really trying our best. Everyone's really very committed to helping mothers and babies, parents and babies. But then whole movements, if you like, commence around a particular inappropriate medical diagnosis, whether it was the gastroesophageal reflux disease from the late 80s, early 90s, whether it was diagnoses of allergy as cause of fussy behaviour and therefore take all of these foodstuffs out of the woman's diet, or whether it's blaming the unsettled behaviour on oral connective tissue tightness. So that's not to say that there aren't some babies, of course, who have allergy, and that needs to be appropriately managed. Typically not causing unsettled behaviour, typically manifesting in other ways, but you know, we don't want to miss a true allergy, but we're typically over-diagnosing allergy. And it's not to say that we don't want to intervene very often for a classic tongue type, but the wonderfully diverse range of anatomic variability in the connective tissues is being medicalised, and unsettled behaviour and breastfeeding problems inappropriately attributed to that, when actually there's underlying issues of fit and hold, or a suite of other things going on.
Yeah. So really coming back to that behavioural side of things, and not,
which is complex to sort out. You know, we need the multilateral strategies. We need an integrated approach. That's why in NDC we're not just teaching a new approach to sleep, or we're not just teaching a new approach to breastfeeding and feeding support. It's really, it does need to be holistic. This is genuinely holistic care, integrating in the mental health support, which we can do in simple ways in our coalface, if you like, coalface consultations. There's some small strategies that can be very helpful to parents from the point of view of mental health, even as we're focusing on other clinical problems as well.
Yeah. I heard you mention earlier about the research that has been done and looking at different interventions or methodologies that are not necessarily appropriate for the clinical setting. And I just wondered about, you know, I know that in lifestyle medicine we have the shared medical appointments or group appointments, like the idea of bringing mothers or carers together with their babies to actually have that peer support and to share experiences together. You know, the use of those kinds of models to support those first 100 days.
So I've been with my colleague Renee Keogh running shared medical appointments in the Possums Clinic for years, and we're currently running them in a gorgeous hall down by the water in South Brisbane, and parents just love them, mothers love them. So we do the younger group, mothers and babies 0 to 3 months, and then the older group, parents and babies 3 to 4 months plus through the first year of life. And the shared medical appointments are a very powerful tool for sharing information according to the needs of those who are in the group, but in a way that offers rich peer support. And in fact, now outside in the park next to where we hold the shared medical appointments, there's just weekly meetings of women who met in our shared medical appointments and then just continue on socially. Thanks to John and Gary for their extraordinary work around shared medical appointments. I trained with them, and then with their consent, translated it into the perinatal period and have been delivering SMAs.
Yeah, fantastic. And you know, really forming those connections with your social support network at that early stage, and that continuing on through childhood. That's fantastic.
That's right.
Beautiful. Well, Pamela, that is all we have time for today. Thank you so much for your knowledge and wisdom and experience in this area. And of course, all of the this webinar has been recorded and will be available to members of ASLM through the member section of our website. So if you would like access to that, you'll be able to access that there. And I believe we'll also make a copy of the slides available as well with Pamela's consent. So thank you for joining us today, Pamela. We look forward to hearing more and seeing where all this work goes. And yes, if you'd like to stay in touch with Pamela or with ASLM, please do so. There's a lot of work, great positive work that is happening out there in the world, and it's great to be a part of it.
Thanks very much, Jordana. It's been a real privilege.
Beautiful.
The opportunity to speak today. Thank you.
Thank you.
Bye.